time in Boston at this time, and so definitely miss home and share the sentiment. We're very fortunate to live and work where we do. The topic that Matt and I are going to jointly cover, and I have to say it's real fun to do this with Matt, is to talk about preemptive deceased donor kidney transplantation, and really to walk you through a rationale for a proposed change in our current policy. Next slide, please. Neither Matt nor I have any financial disclosures relevant to this presentation. Next slide. So our objective really here is to cover the rationale for a potential change in deceased donor kidney allocation policy in BC to allow preemptive transplantation for patients to access expanded criteria deceased donor kidneys. Next slide. Realizing that all these lingos are sometimes a little bit foreign in terms of relevant background, a preemptive transplant is defined as a transplant that occurs without the prior requirement for dialysis. And in Canada, preemptive deceased donor kidney transplants are not routinely performed in any province. If you look internationally, there is significant variation. Most notably, the United States does allow patients to be listed when their estimated GFR is less than 20 mils per minute to potentially access a preemptive deceased donor transplant, but that's not the case in many other developed countries, including Australia and New Zealand. The expanded criteria donor definition is a donor who is, this is a deceased donor who is greater than 60 years of age, or a donor who is 50 years of age or greater with any two of the following conditions. One, a history of hypertension. Two, their cause of demise is due to cerebral vascular accident. A pre-terminal creatinine greater than 135 micromoles per liter. So that's what defines an expanded criteria donor kidney. For our purposes, as Matt will talk about, there's a different designation which is based on a KDPI score, which he'll get into. But operationally, really what we're talking about is deceased donors who are better than 60 years of age. To also, by way of background, what is our current algorithm? So you do not accrue preemptive waitlist time, so you cannot be listed. So all of our patients are backdated to their dialysis start date, and we currently allocate kidneys based on waiting time. Obviously, you have to be ABO within ABO blood group compatibilities and HLA compatibilities, but then we do age match. So if the deceased donor is under the age of 35, those kidneys are preferentially allocated to recipients under the age of 55. If the donor is greater than 60 years of age or meets the ECD designation, those kidneys are allocated only to recipients who are greater than 55 years of age. And then in the donor age category of 36 to 59, who are not ECD candidates, those can go to any recipient who is over the age of 18 years. And that data was based on modeling that we had done way back in 2005, and it served us well, and it forms the basis for what's done around the different provinces. So there's similar age matching approaches used in other provinces. Next slide. So just in terms of how we're going to approach this topic, I'm going to review a couple of seminal studies related to preemptive transplantation and really what we understand about how to best benefit patients with transplantation for an expanded criteria donor kidney. Matt is then going to take you through relatively new data that was published in CJASN that Matt led, that our group led from an epidemiological perspective, talking about the preemptive use of ECD kidneys. And then at the end, we're going to have a bit of an open discussion that we'll hope you'll participate in as well, talking about implementation. So I'll start with a background in terms of preemptive transplantation. And the first thing is that reviewing this makes me feel old. So prior to 2002, there really was uncertainty about the benefits of a preemptive transplant. There were, in fact, significant concerns that were out there. And the first is, if you do a preemptive transplant, are you failing to maximize the use of native kidney function? And is that a bad thing? Also, there was a concern that, you may have a higher rate of rejection because of the immunosuppressive effects of uremia are not fully manifest. And then there was this other notion that for some patients, exposure to dialysis was important to help assure post-transplant adherence with the requirements of transplantation. So there was significant concerns about preemptive transplantation at that time. They seem somewhat silly to me now, but these were real items. And then in terms of the advantages, I think we're all more attuned to this. We obviously want to avoid the morbidity associated with starting dialysis, creation of dialysis access procedures, but also the potential to reduce costs. So this is what was the sort of pros and cons of preemptive transplantation prior to 2002. Next slide, Matt. So I was fortunate enough to work with Bert Kaczynski on this paper. This was actually while I was still a fellow at Tufts at the time, and I would say it's probably one of my first significant epidemiological publications. And really what we did in this study was to figure out not only who accessed preemptive transplants in the United States, but also what the outcomes were. For the sake of brevity, I'm not going to focus on the issue of who accesses them, preemptive transplants in the United States, and just to really focus on the outcomes in this presentation. Next slide, Matt. So here are the Kaplan-Meier survival curves. At the top is patient survival, and these are for deceased donor recipients. And there's, I think, approximately 30,000 patients in this analysis. So the top is patient survival, and the bottom curve is death-censored graft survival. You can think of that as pure failure of the kidney, i.e. the outcome of return to dialysis or the need for repeat transplantation. And what you can clearly see in this graphs is that there is a statistically and clinically significant difference for patients who received a preemptive transplant in this unadjusted analysis for deceased donor recipients. Next slide. The same is true for living donor recipients. Again, the top panel is showing you patient survival, and the bottom panel is showing you death-censored graft survival. You can appreciate that there is both a clinically and statistically significant difference in both of these outcomes for patients who received a preemptive transplant. In terms of a multivariate analysis, what's being shown in this slide, just to orient yourself, is back then we still used the word cadaver, so that's how old this is. We obviously now refer to this as deceased donor transplants. So these analyses are basically stratified by the donor source, whether it was a deceased donor or a living donor. You can see the numbers: 25,000 deceased donor transplants and just over 13,000 living donor transplants. And the thing that you need to focus on in this slide is the top hazard ratio for preemptive transplantation compared to a non-preemptive transplant. And you can see that in the overall analysis, there is a significant reduction in the risk of this is all-cause graft failure, so including death in this analysis as the outcome. And importantly, you can see that this was consistent across a variety of different subgroups in terms of the benefit of preemptive transplantation. Matt, you can go to the next slide. Now, we looked at this in the Canadian context. This is unpublished data that I ran with Ed Cole quite a number of years ago based on core data. And the issue here was obviously there's differences in primarily at that time, our main concern was differences in the provision and the quality of dialysis care. And you can indeed see in these curves that they're not as marked here. We unfortunately, the designation isn't as pure as just preemptive, non-preemptive. We did stratify it as a function of the amount of time that patients were on dialysis prior to transplantation. But I think you can see in the green lines that clearly the preemptive group do land on top in terms of the survival. So clearly that group differentiates. But one of the takeaways that we had from this analysis was that, in terms of exposure to dialysis and an association with adverse post-transplant survival, it really became manifest when dialysis exposure was more than 3.5 to 4 years. Next slide, Matt. So as I mentioned, in Canada, we do not practice deceased donor preemptive transplantation, but this is the utilization in the United States. And you can see going back to 2010 through to 2022, approximately 10%, 10 to 12% of all deceased donor transplants performed annually in the United States are actually done preemptively. Go to the next slide, Matt. So that's the data I wanted to review with regards to preemptive transplantation. And now what I want to review is what we understand on how to best utilize expanded criteria donor kidneys. Next slide, Matt. So just to put this slide in as a frame of reference, I know that a lot of the audience doesn't think about how we think about survival advantage in transplant. This is a seminal study from Robert Wolfe at the University of Michigan, which really established the primacy of kidney transplantation as the preferred therapy from a survival perspective compared to dialysis. The way to interpret this slide is to know that day 0 is the date of the transplant, and along the x-axis you have different time points after transplantation. The y-axis shows you the relative risk. And the people in the dotted line are people who are waiting for a kidney transplant. So this is a time-dependent model. So you can think of the people as in the dotted line as people who remain waitlisted at those different time points compared to someone who got transplanted. And so what you see is that there's an error in the early perioperative period. For 106 days, patients are at a higher risk of death. Thereafter, their risk of dying falls below that as if they had never been transplanted and remained on the waiting list. But to make up that additional risk that the patients have passed through, the survival really equalizes after about 8 months or 244 days. And thereafter, patients who receive a transplant have a survival benefit compared to people who remain waitlisted. And this was the pivotal study that, we'll never do an RCT of dialysis versus transplant. This is the pivotal observational study that established the survival benefit of kidney transplantation compared to dialysis. We go to the next slide. This then was replicated specifically for patients who were receiving an ECD transplant compared to the alternative. And the alternative here is not just waitlisting, it's waitlisting or receiving a better quality kidney or a standard criteria donor kidney. So the graph is set up in the very same way, but the dotted line here includes not just being on the waiting list, it also includes receiving a standard criteria donor kidney as the reference group. And the rest of it flows pretty much the same. You can see, go back there, Matt, sorry, on that graph there, thank you. The rest of it is pretty much the same. You see that there's an early perioperative mortality risk associated with an ECD transplant. You can see that risk equalizes at a longer time point, 226 days, as opposed to 106 days in the previous graph, which was really based on standard criteria donor kidneys. But thereafter, the pattern is very similar. The risk falls below the alternative, which is staying on dialysis, waiting for a standard criteria donor kidney. So this demonstrated that these kidneys do provide a survival benefit, albeit it takes a longer period of time, and that the perioperative risks are higher in terms of relative risk with the transplant of these kidneys. And this was a seminal work from Bob Marion at the University of Michigan at that time. You can go ahead, Matt, on this one. And what was important here, though, is that that graph I just showed you wasn't uniform in all patient subgroups. And what the Marion group did in their analysis is they really tried to make it clinically relevant in terms of who should be accepting these ECD kidneys. And so the analysis that you're seeing here is based on waiting time, and they divided it into 1,350 days, which is about 45 months. And what you can see here is that the hazard ratio, so if you look at first on the left for patients who have an anticipated waiting time of less than 1,350 days or 45 months, you can see that the only group that benefits from this, from accepting an ECD transplant, are those who have diabetes. So they have a higher risk of mortality on dialysis. And so really it only benefits patients who are diabetes if the waiting times are quote unquote short, i.e. less than 1,350 days, which is pretty long time. And then if you look on the right-hand side, you could see that when we get into regions where the waiting times are longer than 1,350 days, there is a benefit across the board, but clearly not for patients under the age of 40. And Matt, if you take that forward into the next slide. Sorry, that went backwards. Go forward. You can skip this one. Thank you. What you can see is what Marion did was put this into an algorithm that could be used to counsel patients as to whether they would want to accept one of these expanded criteria donor kidneys. And so basically walking you through this, if you were younger than 40, you were not a candidate for one of these kidneys, or you should not be accepting one of these kidneys. If you were over the age of 40 and you have diabetes, you should accept one of these kidneys. And then if you did not have diabetes, it really came down to where you lived and what your anticipated waiting time was. We'll skip the Hispanic issue because it's not really relevant to us. And it's actually a bit of a weirdo thing that probably hasn't held up over time. But basically, if you were over the age of 40 and you were non-diabetic, this was something that you should consider if your waiting time was greater than anticipated waiting time was greater than 1,350 days. Now, importantly, although this evidence was out there, in the United States, it was never mandated that only these subgroups of patients who would benefit from accepting an ECD kidney would actually be able to access it. It was still, anybody was able to say, yes, I'm willing to accept one of these ECD kidneys, even if you're under the age of 40. So they left it to the patient decision in terms of whether they would accept them, although the evidence clearly showed that there's certain subgroups of patients who would not benefit from the transplant of these kidneys. Go ahead, Matt. Now, this slide shows you what has happened with waiting times in British Columbia going back to 10 years. And I thank JAG for pulling this data for me. And it's important here that how you interpret this waiting time. This is the waiting time of people who actually received a kidney transplant. Okay, so it's different than when you start your patient just on dialysis, because some of those patients will be delisted. Some of those patients may die while they're waiting for their transplant. And so this is not what exactly comparable to the projected waiting times of 1,350 days that I showed you in the Marion analysis. So that's a true median waiting time of what you're anticipated to wait. So these times are appropriately shorter because these are the times for people who actually got a transplant. I hope that nuance is clear to the audience. And the key thing here is it was within all blood groups. And so don't focus on the AB blood group because it's a relatively small group of patients and those numbers can fluctuate quite a lot. We generally have a relatively small number of patients listed who are blood type AB. But if you look in the blood type A, blood type B, and blood type O, you can see that over time, we have had a significant decrease in the median waiting times of people who received a kidney transplant. Go to the next slide, Matt. Now, why is that the case? I mean, one of the factors is obviously the opioid epidemic, but the other piece of this that has contributed to this is we have a unique model of working with our OPO, which is BC Transplant, in how we work up potential deceased organ donors. So as you know, in this province, we have mandatory reporting of a potential in-hospital death to BC Transplant. And so the law is broad, and so you can see that over this time period, which is 2016 to 2019 data that I'm showing you here, there was almost 1,950 referrals to BC Transplant and patients who were less than 75 years of age who were dying in hospital. And from that, you can see that a huge number of those patients, almost 1,200, 1,194 of them were excluded because of comorbid conditions. So this was done by a triage process by BC Transplant coordinators. So they have a checklist. So malignancies, end-stage organ, multi-system organ failure, et cetera, those patients would be excluded. And so a large number of patients are then excluded. But then when we actually have a potential organ donor who doesn't have obvious contraindications to donation, the one thing that we should be very proud of is the consent rate for those potential organ donors. You can see 587 of those 754 potential organ donors actually consented for organ donation. If you punch that out, that's over 80%. And so there is no need in this province to go to a presumed consent model. When we approach people in a culturally sensitive way, they overwhelmingly endorse organ donation, and this data proves it. So we do not need to follow what's going on in Nova Scotia. Then when we get to the potential consented organ donors, you can see that we now do more advanced testing, imaging, laboratory testing, and so forth. And so another group of donors fall out, but 80% of the consented donors, so 480 out of 587 is just over 80% of those go forward as eligible kidney donors. And then you can see that what the major loss then is in donation after circulatory death donors who do not progress to cease circulation in a time that is compatible with organ donation. So we lost 42 donors because of that. But once we then go to actual kidney donors, meaning we cut skin to recover organs, we utilize almost 93% of those organs, and that is strikingly high, and in contrast to what happens in most other jurisdictions in the world. So this is a very efficient organ donation system that I would say in 15 years, for a number of commitments that have been made by our program as well as BC Transplant, is now amongst the highest performing in the world. So that's the reason why the deceased donor times have come down. Matt, you can go to the next slide. So the reality now is if we go back to say, well, why would my patient accept an expanded criteria donor kidney? The trade-off has to be a shorter exposure to dialysis. But now with our waiting times falling to where they are, that bar can really push this now to where we can actually talk about preemptive listing for these expanded criteria donor kidneys. So if you think about it, well, what would we do with these expanded criteria donor kidneys? We would either not use them or ship them out to a place that has longer waiting times, or we would move the bar to offer them preemptively to patients in British Columbia, and that's what we're proposing. Matt, next slide. And so now I get to take a break and turn this over to Matt, who's going to take you through some exciting new data about the use of these kidneys preemptively.
Thanks, John. And thanks everyone for this opportunity to talk to you. It's really exciting to present this data from a study that we've been working on for a very long time to get off the ground. And John set it up well in terms of the introduction for this, but really the data that John presented earlier about preemptive transplant and the benefits of preemptive transplant was kind of a broad strokes assessment, really didn't look at the specific question. Does preemptive transplant of using high KDPI kidneys still provide the same benefit that we saw with preemptive transplant in, say, living donors or other circumstances? So we did this study with the question is, does the benefit of preemptive transplant of deceased donor kidneys extend to recipients of ECD kidneys? Just in terms of the terminology that was used in this study, so we did use a slightly different way of quantifying, for lack of a better word, the quality of the donor or the expected graft function of the donor. So we used a metric called the Kidney Donor Profile Index. This is used commonly in the United States as part of their allocation algorithm. It's a percentage metric from 0 to 100%. 0% means basically that kidney donor would have the expected graft survival of the best kidneys of the kidneys transplanted in the year prior, whereas 100% on the other end of the spectrum would mean that this kidney would have the worst expected graft function of the kidneys transplanted in the year prior. And when we look at the correlation between KDPI and ECD criteria, really around 85% is where the cut point would be between standard criteria donor and expanded criteria donor if you were to line that up in terms of concordance with the KDPI as is shown in this graphic here. So the study that we performed was based on US registry data. We looked at adult recipients of deceased donor kidney transplants from 2005 to 2017. The US data was really important in this analysis because, as John mentioned, anywhere between 9 and 12% of kidney transplants in the United States are performed preemptively. We excluded multi-organ transplants, previous transplant recipients, and the only one instance where we were not able to calculate a kidney donor profile index. We're left with a very robust cohort of 120,000 patients, and we stratified these into groups by kidney donor profile index. And that left us with around 23,000 in the high KDPI category, between 85 and 100% KDPI. And within each of these categories of KDPI, as I mentioned, between 9 and 12% were transplanted preemptively. So in terms of the unadjusted post-transplant graft survival, these graphs are Kaplan-Meier curves of all-cause graft survival. So graft loss could be from either death or graft failure prior to death. And in all categories of KDPI, whether that's the 0 to 20%, which is the best kidneys, or greater than 85%, which is the ones with the lowest expected graft function from the year prior, as calibration, we see that there is a benefit from preemptive kidney transplantation in terms of expected graft survival. Now, it's important to note that there are obviously many factors that go into when someone may get listed preemptively for kidney transplant. There certainly are socioeconomic factors that can play a role that may also have may confound this analysis, but this broadly in this unadjusted model, there was benefit in terms of getting a transplant preemptively, even in the high KDPI category, which would be our expanded criteria donor category. We then went on, of course, to do a multivariable analysis to adjust for some of those factors that we could. So the factors that we adjusted for included age, race, income, the insurance status, the cause of kidney disease, to name a few. And again, this is stratified in slightly different cut points because we wanted a little bit more granular data in terms of the high KDPI donors. So we've stratified this a little differently, that there's now a category of KDPI 81 to 90 and then 91 plus percentile. These are the hazard ratios plotted graphically of a risk of all-cause graft loss in both the non-preemptively transplanted recipients, which are shown in the gray dots with the error bars there, and the preemptive recipients, which are in the black dots. And you can see that in all categories, again, that preemptive transplantation was associated with a much lower risk of all-cause graft loss. But furthermore, even in the 91% KDPI group, 91% or higher, when you use those kidneys transplanted preemptively, you've got a very similar risk of graft loss of a much lower KDPI percentile, suggesting that you can get a substantial improvement in graft outcomes if these kidneys are used preemptively. One of the challenges, though, with this analysis is the adjustment for donor factors and the features that go into organ allocation that aren't always measurable in registry data. And so we were able to do what we call a mate kidney analysis, which is where we look at with each donor, there's 2 kidneys that can be transplanted. And we were able to look at this analysis in the sets of donors where 1 kidney was used preemptively for transplant in one individual, and the other kidney was used non-preemptively in a patient who was on dialysis. And once again, this was stratified across categories of KDPI. And in all categories, there was an improvement in terms of expected all-cause graft loss if the kidney was used preemptively, which is shown in these these dashed lines. And so all of these analyses are strongly suggesting that there is an association with improved graft outcomes when we use even the highest KDPI category kidneys, i.e. the ECD kidneys preemptively. We did try to look at some potential mechanisms of this, and one thing that we did find is that the association with DGF is really an important factor. Whether this is causal or on the causal pathway is unclear. But we found in this analysis where we stratified both preemptive and non-preemptive recipients by whether or not there was DGF. So we can see this is a little bit small, but it basically, this blue line here, this dark blue line is preemptively transplanted patients who had DGF. This green line is non-preemptively transplanted patients with DGF. The red line is preemptive transplanted patients without DGF, and the yellow line is non-preemptive transplants without DGF. And you can see very clearly that the all-cause graft outcomes are similar to, in the groups that had no DGF, and they're similar in those who experienced DGF. And really the risk of DGF in a preemptively transplanted individual is very low. So there's only 900 patients that had DGF in preemptive transplant, and that was less than 10% of the cohort, compared with closer to 35 to 40% in those who are non-preemptively transplanted. So this may be one potential mechanism by which the outcomes are better in patients who get a preemptive transplant, is the avoidance of DGF, which we know is associated with lower graft function and potentially rejection as well. There are still a few things that we don't have sorted yet. The first is kind of a decision analysis similar to what was done by the Marion group in deciding which patients would benefit most from preemptive listing for ECD transplant. Preliminary results suggest that anyone over the age of 65, both diabetic and non-diabetic, would benefit not only an improvement in life expectancy, but also a reduction in cost. And we also don't know exactly what the impact on the utility of the deceased organ pool in BC would be. We're planning on doing dynamic cohort modeling, both kind of prior to any policy change implementation, but also post-implementation, to determine how this would affect our wait list and also our collective post-transplant outcomes. So I'm going to switch back and send it back to John for starting the discussion of how we're thinking about implementing this in BC.
So just by way of background, I think when Matt presented that study, just for the reference was cut off, that paper was published in CJASN in April of 2023. And just by way of context, 2/3 of KDPI kidneys over the 85% mark are non-utilized. We don't use the word discard. They were non-utilized for transplantation. They were recovered. And so in this coming year, it is shocking that 8,000 deceased donor kidneys will be non-utilized in the United States for transplantation. And parenthetically, as an aside, I think that this paper has already had a significant impact in utilization, combined with a change in allocation policy where they allow open offers. So basically a kidney which is at risk of non-utilization, which these high KDPI kidneys or ECD kidneys clearly are, become an open offer, and they are now being overwhelmingly used preemptively. And I just got that information at my meetings here in Boston. So the work that this study is actually putting forward is invoked a change in practice in the United States, which I think is really quite exciting to see. But what we're talking about here is bringing the story back to British Columbia. And so the real issue for us to discuss here as a community is the fact that for very good reasons, we now believe that we should be considering preemptive access to these high KDPI kidneys or ECD kidneys for patients in British Columbia. And what I think the devil is obviously in the details of how you implement it. Implementation of a new policy always has the potential to leave some patients behind, and for some unfairness for patients who are already listed. Here's our initial thoughts on this, and we would welcome your feedback either during this webinar or afterwards by direct email, because we do want to get input from all the relevant stakeholders before we go ahead and make a change. But what we're proposing is to maintain our current age-based cutoffs for allocation. So changes would be limited for patients who are over the age of 60 years of age. If you were already on the waiting list and your waiting time was already greater than 45 months, it would not make sense for us to continue to allocate a high KDPI or an ECD kidney to you. So we would then offer those patients that have already waited more than the 45 months, only deceased donor kidneys in the age bracket of 35 to 59. For prevalent waitlisted patients with a waiting time less than 45 months, they would still receive offers from donors aged 35 to 59, as well as donors over the age of 60. So that's how we would propose to amend the allocation for people who are already waitlisted. But what would be new would be for patients who are not yet listed and not yet on dialysis, If they were preemptive, they could be preemptively listing if they were better than the age of 60. Their waiting time for a non-ECD donor would still start at the time that they started dialysis. So they could not gain access to a lower KDPI kidney preemptively, but they would be eligible to receive an ECD kidney from a deceased donor over 60, which, as Matt has shown you, is associated with very good outcomes. And that's what we're proposing. And so, Matt, I don't know if you had any additional comments on this implementation piece, because you and I have been in different cities last week. We haven't had a chance to discuss this openly, but Matt, did you want to add any comments to this? And then we're actually ready to open it up for some discussion. We hope there is some. It's tough on this webinar platform, but we do hope to hear from you. Matt?
Yeah, thanks, John. I think, in terms of the only other thing I think is really important is that, when we talk about preemptive transplantation, the eligibility criteria is also another really important thing. So obviously this is going to be transplant eligible patients. But I think that the key thing is that this provides a lot of benefit for patients who, we would think would have a very potentially poor chance of survival to transplantation with our typical allocation algorithm, who would need to start dialysis and then wait for years for kidney transplant. So there's a lot of benefit to this for our patients. But I think also it's going to an ongoing challenge, and something we haven't sorted out fully is kind of establishing which criteria. We all know there's patients that are over the age of 60 who have very stable GFRs at 15. But broadly speaking, we would be looking at patients with a GFR less than 15 before listing. I think that would be the only thing I would add to that.
Yeah, and that's a great point, Matt, because I think that one of the things that we have to be cognizant of is creating disparities. And so it is a reality that our kidney transplant programs have limited resources. So you can imagine that if there's a flooding of referrals for preemptive deceased donor transplants for patients over the age of 60, the first thing is we would look at people who are anticipated to be starting dialysis in the next year. So we would want people with progressive disease, and as Matt said, we could use a cutoff of 15, but also evidence of progressive disease. To make things fair for remote dwellers and for patients that are from ethnic minority groups, including Indigenous patients who we know have trouble negotiating the pre-transplant evaluation or completing it for a variety of reasons that are out of their control, we would seek to actually prioritize the evaluation of those patients who are living in remote areas and from certain ethnic groups that we know have difficulties in completing our pre-transplant evaluation. And that's because you could imagine that if we open this up and it was only people in the lower mainland who clearly have advantages in terms of accessing and completing the pre-transplant evaluation process. So there would be some attention that we would want to pay to not create another level of disparities in access to transplantation through this preemptive mechanism. So those would be key considerations that I would add. And I hope that others on the call will have more. I see we have one question now. It's from Dr. Singh. Is there an opportunity to build equity for, yes, exactly what we're talking about, Anurag. We would welcome your thoughts on how to best achieve that. We're very sensitive to the fact that people, particularly in your health region, and also more rural dwellers could be disadvantaged, and we wouldn't want to do that. So that would be an important thing. Kevin Horgan's asked a question about the KFRE. Kevin, I think that's one way to look at who's going to progress. So certainly we don't want someone who's stable with a GFR of 20 for the last 5 years, getting preemptive access to transplantation. But I think that is one important consideration, Kevin, in terms of predicting who would progress. The other piece that Liz Hendren, who's a new investigator here, is actually advancing is, one thing we are sensitive to is that the referring physicians don't often know the blood type or the CPRA of patients. So how we would incorporate that into is something that we might think about as well, Kevin. But your point about a KFRE type equation is a good one. I don't know if anybody's going to come online, but I appreciate those questions. we'll wait for a bit while people are percolating on this because
And David Landsberg has his hand up.
you see that. Dr. Landsberg.
Hi, guys. Great
David.
talk. Certainly it's wonderful that we are at the point where this is a viable discussion without because of our outstanding success in in deceased donation. But I want to focus on the fact that we continue to believe, and it is true, that deceased donation is a good option, but living donation is a better option. I think this is a great idea, but I do worry that when we're talking in the preemptive space, that this will further de-emphasize. And I think right now, where we're seeing living donation being most successful is in the preemptive space, because people are now figured out that once I get on the waiting list, I'm getting a transplant really quickly. If I'm now in the preemptive space and I'm going to get a transplant really quickly, will that further de-incentivize people to go for living donation? Which clearly, if you're 62 years old and you could get a preemptive deceased donor, but you could also get a living donor, I would getting a high KDPI deceased donor kidney, I think you may very well be looking at needing a second transplant in 8 years, whereas if you had a living donor, it would probably last you the rest of your life.
Yeah, David, it's a great point. I think one of the issues that I didn't cover here is I highlighted the issue of the perioperative risk. So one of the advantages, there's multiple advantages to living donor transplant. And so when we and obviously one of them is obviating waiting time. So if we introduce a mechanism where people can basically wipe out that waiting time, what are the other main considerations when we counsel these older patients about why a living donor is still the primary consideration for them? In addition to the one that David mentioned, which is the longevity of the kidney. So we're talking about one kidney for life. So these kidneys do have reduced long-term survival. So the possibility that you could have to return to dialysis is definitely higher with these ECD kidneys. But the other issue is the perioperative risk and the recovery time. So I did not show you slides, but in a future presentation, we can review data on the transplantation of patients who are over the age of 60, what the perioperative risk is with acceptance of a living donor versus a standard criteria donor versus an ECD donor. And there is no question that a living donor is by far safer from a perioperative road to recovery perspective. And I think David's point's right on, that we certainly do not want to compromise the primacy of living donation and preemptive living donor transplant. So David, those are really important points. Thanks for those. I see that Thomas Ng, and then I'm going to come to Dr. Bulio.
Sorry, John, I'm just going to add on to what David was commenting on. And I think one thing we should also be considering is, with the work that's been done with Transplant First, and also the potential for preemptive assessment by a transplant physician, there's also the potential that we could see more opportunities explored for living donor transplant, as long as the transplant programs are still prioritizing living donor as the number one option. I think one of the troubles that sometimes people have is getting contact with a transplant team and understanding those benefits of living donor transplant. They may not always be spelled out for them. And so there could also be the added benefit that we're going to be seeing more of these patients before they need to start dialysis. They may have more time to explore the option of a living donor transplant.
So Thomas has a question about what about repeat transplant candidates? And so Thomas, the way I'll answer that question is to say that there are other groups who may warrant consideration for preemptive access to a deceased donor transplant. One of them would be the highly sensitized patient group, which would include a significant proportion of our previously transplanted patients, not all of them. So right now, we would be proposing this for first transplant recipients. There are other groups that potentially could be considered for preemptive transplant, but right now, this would be for first transplant recipients. Monica, go ahead.
Thanks. Thanks, John. Thanks, Matt. I guess working primarily in the non-dialysis advanced CKD space, I'm actually a bit less worried about not being able to layer the importance of live donor transplant first. And I would say that right now in the current environment, most individuals do know that benefit as the first thing. In addition to everything David mentioned, it's also time, time control. There's a lot more control with living donation as well for those people. My question is, have you guys thought about even using a GFR cutoff plus minus a KFRE cutoff, where we're going to start the clock for these individuals, just in the preemptive space? Has there been a discussion about, because we're so clear and it's so easy with a dialysis cutoff? Is it at submission? Is it at acceptance? Have you thought about a time not for these preemptive patients?
I have, Monica, and some of the issues obviously are, first of all, with estimating kidney function accurately, right? If you followed the US literature, there's been a huge stink about exactly how you set the eligibility criteria. So I think that needs to be more discussion about that. I do think the KFRE model is one that we could predict, and we certainly would welcome more input into that. I think in general, we do not want this to be a huge, as Matt says, we want to have this as an option for people, but still to have living donation as front and center of it. I do think that the patient selection criteria, which is related to, I think, Dave Nichols' question about how many patients would be eligible for this, I think we do need to think about something like a KFRE model, which we have not done yet. So,
yeah, and then just to, something we're challenged with is on our potential preemptive donors in a kidney clinic, about 30% are PKD patients where the KFRE model doesn't apply at all. So just layering that into the discussion as well.
That expertise and insight is very helpful. We do not think about KFRE in transplant, so would welcome how to apply that to this setting.
I think just to add on to what John has been saying as well, like the concept of preemptive deceased donor listing for these ECD kidneys is still fairly early in its development. I think this is where we're trying to move forward, so we can maximize our deceased donor pool. And certainly these comments about the risk of progression, ranking patients on the wait list are all things that will need to be carefully considered before implementation. This is likely not something that's going to be, tomorrow in terms of implementation of policy. So we've got lots of time for input and really appreciate these insights from the kidney, particularly kidney care clinic where this work will be the hardest.
Suneet has raised another important issue, which is patients are reluctant to begin the journey towards planning for renal replacement therapy, and this may complicate that process. Suneet, that's a very valid point. I think that, it is one that our education piece around this is going to be high. What I think would be important is, remember, we're talking about people over the age of 60, but certainly all of those issues in terms of vascular access planning and so forth need to be integrated into this. And you're absolutely right. This could lead to a reluctance for people to make a decision. And I think that that's definitely an unintended consequence that we will need to actually engage with you all to make sure that is communicated in a way. So I know I'm dancing on not answering your question directly, Suneet, because I think it's a tough one. But I think we are going to have to think about that carefully. So other than to thank you, I don't have a solution for that other than we're going to have to address that head on. Someone who is too afraid to tell us who they are, an anonymous.
Oh, actually, I think we have questions from some hands up first before.
Okay, go ahead, Matt. Sorry, yeah.
I think Kevin Wen was the first one, and then Mike Copeland after that.
Yeah. Thanks, Matt and John. Excellent presentation. Congratulations on this. I think this is only made possible by such high donor rates and acceptance rates in BC that has been worked on for many years. A question about the prevalent wait-listed patients, as most blood groups are now waiting quite a short time frame, less than 45 months. In terms of those who are already on the wait list, it would almost seem like it doesn't make sense to even give somebody, let's say blood group O, an ECD kidney, and maybe allocating those to the preemptive. Or should we have a way of trading off wait times for those who are eligible for an ECD kidney for a shorter wait time blood groups to basically be prioritized?
Matt, do you want to handle that? I think I tried to address that, Kevin, in that initial slide, and I don't know if we can.
Yeah, I think, in reality, when we're looking at this implementation, the fact is we will have to have essentially two separate wait lists, for one for ECD and one for SCD. And the trade-off being the wait time, because really the only times that you will get a benefit from having a separate allocation for ECD kidneys is if one of two things is achieved. Either you improve your utility of kidney transplant or kidney donors. So while that's not realistic here in BC, where we have a high rate of utility, we're not really discarding any kidneys. It is in other places. And the other advantage is when you actually offer a benefit in terms of wait time for your recipients. And so I think that what we'd probably be looking at is separating out the allocation algorithm, and let's say the things change with a deceased organ donor pool, and for whatever reason we have a decrease in deceased organ donation rates and our wait times go up, then it would actually make sense to just offer a separate wait list for ECD if it provides 2 years of benefit, for example, or whatever cut point we assign. And that way we can allow patients who have started dialysis to still get a benefit from an ECD donor, as long as their wait time is shortened because of that. I hope that makes sense.
Yeah, fully in agreement.
Thanks, Kevin. Mike Copeland didn't actually have a question, but there's an anonymous question here. Can you expand possible strategies to prioritize remote and underserviced populations? It's a great question. I think that, number one, we don't know what the referrals would look like. So imagine that we've actually implemented this policy and you folks are now all referring patients preemptively for consideration of transplantation. Obviously, I think that we would know the location of where the person is coming from, and there already are discussions about prioritizing remote dwellers. But it would be a triage system that would be transparent to all of you. So our commitment to you is as follows. This is the first introduction of this topic. What we would welcome from this is additional comments that you could send to Matt or myself directly. We will take that back as a transplant group, and our plan would be to come back with a revised policy for implementation. Like any policy that invokes a big change, I think it would be one that would be subject to periodic reevaluation. So the commitment would be to come with something that seems reasonable to most people, implement it, look at how it's working after a period of 12 months, come back to you with data that shows exactly what's happening, and then we as a community can discuss. The whole intention here is to have broad input into this. This is a societal resource. We want to obviously use it to its maximum value in the fairest way possible. And so anything we come up with out of the gate will obviously be well thought out as best we can, but there will always be unforeseen potential issues. So the only way to really make sure that we're doing the right thing and the fair thing for all of our patients would be to bring the data back. So that would be the overall structure, and you would have that laid out for us. So we would propose that if we made this change, we would do it for a period of 12 months, come back with the data, show the community what had happened in 12 months, and then go forward from there.
I think in addition, John, it would be important to highlight that concurrent to these discussions is also the work that JAG is doing with the Bridge program for First Nations patients to help improve their access to living donor transplant, but also streamlining recipient evaluations for patients that are particularly coming from out of town, where it can be quite challenging for them to get through their transplant evaluation. And I think those kind of efforts are really important to highlight as well. And that's happening concurrent to this discussion, which is important for those patients in remote and underserviced areas.
Great stuff. We are at almost time, but if there's one, we could entertain one last question, or please do email Matt and me. This is an important change for us to consider. Getting it as good as we can on the initial go is going to be dependent on your guys' input, so we would appreciate that. And then this is exciting, but it does come with potential unintended consequences as have been highlighted here, and so I think we have to be mindful of those as well. Matt, I guess we can sign off. Thanks very much. It's always a pleasure to do this with you.
Thanks everyone for your questions, and having an excellent rest of your day.